spinal muscular atrophy. And the discussion today really are going to be around what we've all learned over the last few years, which is the dramatic progress that's been made and this actually, quite frankly, comes from our original work in mouse models. The unbelievable success of gene therapy for childhood spinal muscular atrophy. Is this also valuable for adults? So clearly the recent identification of gene therapy for SMA has been one of the most profound therapeutic discoveries in all of neurology. I sometimes think of this as the penicillin of the 21st century, to effectively cure a fatal infant disease of motor neurons. It's also one of the most expensive therapies, however, in all of medical practice. But SMA doesn't affect just infants, it affects adults in a very slowly progressive and also disabling disorder. And the question that we're going to discuss today is, should this powerful therapy, at least in infants, be also applied to adult onset SMA individuals? And this has implications for potentially slowing down this very slowly progressive disease, but also bringing upon the issue of the cost of such a disease. We're going to have two sides in this last discussion. The first, the yes approach, will be Dr. Suzanne Petri, and perhaps not always is going to be Dr. Amos Korzen from Israel. Dr. Petri is a neurologist in Germany, and Dr. Korzen is a neurologist in Israel, and we're going to hear from both of their two sides in a moment about how they think we should be approaching this a little more challenging clinical question. There'll also be a pre-vote of yes versus no, which is about to occur.
Good afternoon. My name is Suzanne Petri. I would like to thank the organizers for giving me the opportunity to argue in favor of an indication of the new treatments for spinal muscular atrophy, which are successful in the young, also in adult SMA patients. These are my financial disclosures. Spinal muscular atrophy is the most frequent childhood onset motor neuron disease caused by degeneration of alpha motor neurons in the ventral horn of the spinal cords. Major symptoms are muscular weakness and in some cases also respiratory insufficiency. SMA is a monogenic autosomal recessive inherited disease caused by deletion or mutation of the survival of motor neuron gene. The incidence is 1 to 6,000. Mutation carriers are 1 out of 40. According to the age of onset, and the highest motor function achieved, SMA can be classified as type 0 to 4. Most frequent are types 1 to 3. SMA is caused by a lack of the SMN protein caused by mutations in the SMN1 gene, leading to the generation of an unstable or inactive protein. Healthy individuals usually carry 2 copies of a second SMN gene, the SMN2 gene. SMA patients usually carry between 1 and 5 copies of this gene. In the SMN2 gene, it comes to mis-splicing within the mRNA formation and thereby deletion of the exon 7, which results in the translation to an unstable and dysfunctional SMN protein. The natural history studies of SMA show that it is a progressive disease regardless of the age of symptom onset and regardless of the subtype and disease severity. Both motor function, here measured by the Hammersmith Functional Motor Scale Expanded, HFMSE, and also respiratory function measured by the FVC, decline over time in all patients. Current therapeutic approaches in SMA consists either in correction of the aberrant SMN2 splicing or in replacement of the SMN1 gene. The earliest approved treatment for SMA has been the antisense oligonucleotide Nucinosan. It acts as a splice switching oligonucleotide, resulting in prevention of the aberrant mRNA splicing and thereby inclusion of the 7th exon into the SMN2 messenger RNA, leading to the translation into a fully functional and full-length SMN protein. Nucinosan has been tested in several clinical trials, among them 2 phase 3 trials. The first one only in infants, the second one, the CHERISH trial, in patients up to an age of 9 years. The primary endpoint was motor function assessed by the HFMSE score after 15 months of treatment. As you can see in the blue line, treated patients gradually improved in their motor function over time, while patients receiving vehicle treatment deteriorated. Significantly positive results were already shown at the interim analysis, so that the study was terminated prematurely and all patients were moved into open label extension treatment. These phase 3 studies led to the approval of Nucinosan in Europe in 2017 for 5q SMA patients of all types and stages in all ages, so also in adult patients which have never been tested in clinical trials. SMA is administered, Nucinosan is administered intrathecally, first in the loading period with intervals between 14 and 30 days, and then in a maintenance period every 4 months. Adult SMA patients show a wide disease spectrum between severely affected, fully wheelchair-bound SMA type 2 patients over type 3 patients, sometimes still able to walk and climb stairs, towards the rare SMA type 4 patients with onset in adult age only and mostly quite well preserved motor function. The German SmartCare register is a platform to collect real-life outcome data of patients with spinal muscular atrophy all over Germany, both in neurological and neuropediatric departments. An important real-world study in adult SMA patients treated with Nucinosan came out of this register and has been published in April 22 in The Lancet, led by Tim Hagenacker from Essen. The study showed clinically meaningful improvements corresponding to an improvement of at least 3 points in the HFSME score in 40% of the included patients. Some patients even improved much more, up to an 18-point improvement in this score. You can see the three major readouts in the study: the HFMSE, the ROLE, the revised upper limb module, which covers upper limb function, and the 6-minute walking test in ambulatory patients that measures walking abilities. And in all three parameters, the mean difference versus baseline was significantly improved. The study also attempted to analyze factors affecting beneficial treatment response, and pre-planned subgroup analysis showed that higher baseline HFMSE scores and the absence of spinal surgery were factors were correlated with greater improvement in motor function. Post-hoc subgroup analysis showed that ambulatory status and SMA type 3 versus 2 also were correlated with greater improvement in motor function in these patients. This is a patient from our clinic who also participated or was included in this study. She developed first symptoms at the age of between 1 and 2 years, leading to a slow progressive motor decline with proximally predominant atrophic tetraparesis. At the age of 16 years, she was diagnosed with SMA. The genetic testing revealed the presence of 4 copies of the SMN2 gene. At 34 years, she first came to our neuromuscular clinic and expressed interest in Nucinosan treatment and became one of our first patients treated with Nucinosan. These are the results of her motor function assessments. Over time, her HFMSE score improved by 2 points from baseline, and her walking ability increased by 60 meters in the 6-minute walking test. These are some videos where you can see her walking and also climbing stairs with some support. She's married, she has 2 healthy children, and works part-time as a financial clerk, and still continues receiving Nucinosan every 4 months at our department. Some of our patients report wearing off of the Nucinosan effects over time in between treatment intervals. Up to 67% of patients, mostly in the last month before the next Nucinosan administration, and higher doses of Nucinosan might be required in some patients to better maintain treatment effects. This is currently under investigation in the DEVOTE study. As I mentioned, correction of SMN2 splicing has been the first therapeutic approach in SMA, and this is now possible not only by intrathecal administration of an antisense oligonucleotide, but also by an orally available splicing modifier named Risdiplam. European approval has been granted in March 22. The mechanism of action is the same as for Nucinosan. The introduction of exon 7 and overcoming of the aberrant splicing of the SMN2 gene, and thereby increased generation of a fully functional SMN protein. Risdiplam has also been assessed in several clinical trials, again starting in infants and toddlers, and some later studies also have included patients of an older age. The Sunfish trial has included patients up to an age of 25 years with type 2 or 3 SMA, but non-ambulatory patients only. The first 12 months had a placebo arm shown in gray. After that, all patients were received Risdiplam treatment. And one can see that motor function improved over time in the first and also in the second year of treatment in these patients. There has been an ongoing debate about the best suited outcome parameters for adult patients with SMA, particularly related to either very severely affected patients where floor effects may occur when using the generally used motor outcome measures, but also in very mildly affected patients where ceiling effects may be seen. So Alma Osmanovic in my team has led a multi-center trial within the German network assessing the treatment satisfaction questionnaire for medication as an additional readout in our Nucinosan treated cohort. And she found that treatment satisfaction correlates well with disease severity, being higher in ambulatory than in non-ambulatory patients, and also with treatment response. Patients who showed an improvement in the WOM score also expressed a higher satisfaction with effectiveness of the treatment. Patients who showed a deterioration in the motor scores also differed in their rating. Patients who chose to withdraw from treatment had lower treatment satisfaction, while patients deciding to remain in treatment despite motor deterioration expressed higher treatment satisfaction. So this might be a sensitive parameter also capturing factors that are not addressed by motor function readouts, but drive patients to wish to continue the treatment. This is another study done in our local cohort at Hanover Medical School, led by my coworker Camilla Binz. She tested questionnaires addressing different dimensions of fatigue, which is a common complaint in adult SMA patients. And she found that different dimensions of fatigue are impacted by SMN copy number, by the walking ability, by comorbid depression and anxiety, and also by education. And she found that several fatigue dimensions decline over time in patients treated with nusinersen, most dramatically the dimension of reduced activity in ambulatory patients receiving nusinersen. So this may become an additional marker of treatment response in SMA, but of course must be tested in larger cohorts. The other therapeutic approach in SMA is the replacement of the defective SMN1 gene by viral vectors. This also has been tested in infants first, and the compound onasemnogene abiparvovec has been approved as single-dose gene replacement therapy for spinal muscular atrophy. It has been approved for SMA type 1 and SMA with biallelic mutations in the SMN1 gene and a maximum of 3 SMN2 copies. Dosage recommendations have been described up to a weight of 21 kilogram, but warnings have been communicated due to the lack of data for children older than 2 years and the body weight of more than 13.5 kilograms, so that the treatment so far has been restricted to small children. But further studies in elder children and also studies addressing an intrathecal formulation are currently underway in patients up to 18 years of age. So I would like to conclude that yes, adult patients should be treated by disease-modifying therapies, so far limited to treatments modifying aberrant SMN2 splicing. Improvement in adult patients is possible, even if it is more likely in patients with lower disease severity based on the real-world data that we have available so far. Stabilization is a more realistic but equally important and desirable treatment goal in patients with more severe disease. Long-term follow-up is necessary to determine whether improvement or stabilization is sustained. Long-term effects still need to be further elucidated, and for adult patients, the best suitable outcome measures and biomarkers must be defined. And the most efficient dosage and treatment regimens in adult patients need to be elucidated in further trials. I would like to thank you for your attention. I would like to thank the local SMA team at Hanover Medical Schools and all participants in the MNDnet and SmartCare registers. Thank you very much.
Dear friends, good afternoon to you. Thank you, Professor Rothstein, for the introduction, and particularly thanks Susan Petrie for the nice presentation that she had. She almost was able to convince even me that treatment of adults with SMA with the new drugs is justified, but not quite. And I will tell you what I think about it. But first, the disclosures, I have none. Firstly, because I'm not a neuromuscular person. And I was called to the challenge because we could not find anyone from the field who agreed to take this challenge and fight Susan in this debate. And I'm not sure why. Maybe it's related to the fact that they like Susan so much, but maybe also because they have financial disclosures that they don't want to show in public. So I took the challenge, and let's see whether I can convince you that the situation is not as simple as you've heard from Susan just a few minutes ago. Firstly, I want to salute to science, because now we are in a new era of science. We can manipulate genetic diseases. This is fantastic. This is something that developed over the past 10, 20 years, could not have been dreamed on before. And this is very important. We see this all over, and with the coronavirus and with other disorders. But now we're talking about spinal muscular atrophy. And in this disease, the clinicians were able, using the new treatments, 3 of them, to prevent progression of death in a terrible congenital disease, but only in infants or young babies. The proof in infants with SMA1 came with a classical method through controlled studies, double-blind controlled studies. This is not the case what happens with adult type. But we also learned in infants with SMA1, I don't know whether Professor Petrie was able to say this, the treatment should be started as early as possible. And this is relevant to what I will go on to tell you later, because in adults, we cannot start very early. By the time we make the diagnosis, the patients have been sick with problems, motor problems for several years already. But in any case, in infants, it is relatively easy to do a prospective, double-blind controlled study, and this is much more difficult in adults, and we just don't have the data on adults. Even in children or in babies, we know that the efficacy of the drug is to prevent progression. Lost neurons are never revived, damage done is not repaired, and there is no good evidence of clinical improvement. So whatever the patient has, this is what they will remain with. They will not improve, but not progress either. So this is a huge success. So this successes in infants led also the investigators to give the same treatments for patients with more at higher age. So what about adults? What about adults who carry SMA 2 or 3 or 4? So in my time when I was still active in the field, I saw patients with Erding-Hoffmann, and of course the question was, how can you prevent them from getting worse? And it is not so simple. Although we must remember that unlike babies, adult type SMA is less severe. The disease progression is extremely slow, taking years. And although disabling, it is not lethal unless there are complications. The approval of the use of these drugs, the 3 of them, for adults came without being based on agreed diagnostic criteria. An available study disregarded the severity and the rate of deterioration, etc. So all the patients that the investigators could include in the study were included. Some of them were more severe, some of them were still very mildly affected. And important also that even now, after several years of having the drug approved, we don't have data or criteria for stopping medication. This is also something which is important. These drugs are extremely important. And if we compare them, for example, to multiple sclerosis, in multiple sclerosis, we know when we should start the treatment, and we know when we should stop it. And we should prevent the drug from being continually used, and also from spending much more money unnecessarily, because in advanced progressive MS, secondary progressive MS, the drugs, anti-MS drugs are not effective. And this may also be true for adult type SMA, but we don't know. So in principle, of course, drug approval should always be based on double-blind, placebo-controlled study, but none are available for adult SMA. And the approval of the drug was allowed because the disease is similar in its mechanism to the infantile type, but it's not the same. But I maintain it's not the same disease. So placebo effects, of course, exist, as I will show you in a minute. But also, in order to show the effect of the drug, comparison is made from baseline levels to the follow-up. And of course, this is these studies are based on selected individuals. In each center that was involved, there was a decision about each patient whether they should be included. Maybe the patients did not agree. Maybe the investigators thought that they were not really the best candidates. And we don't know what are the ecological validity of the data that were presented. And even if we show or we see that there is statistical significance, this statistical significance is not clinical significance. These are different issues. So we need data on the clinical significance of these drugs in adult patients. And not all studies have been positive. Some gave negative results. For example, this one, coming from Oli Moshe-Lili in neurology just recently, came to the conclusion that the side effects of Nucinosan, which we'll talk about in a minute, can be serious, whereas half of the treated patients reported modest improvement, half of them did not do even that. So half reported modest improvement in function. There were no significant objective changes, which may point largely to a placebo effect. So while possibly effective, we do not know the effect size nor the risk-benefit ratio for a specific population. And we don't have long-term data. And of course, we can expect that maybe there will become tolerance. Maybe there will be need for boosters, maybe not. Maybe we give the boosters without needing it. So we rely on retrospective analysis of these studies, but the patients that were included are not representative. The quantitative data which are given are inaccurate, point 1 point more or 1 point less in the Hammersmith scale is not very important, not very, and it's test-retest reliability is small. There is a high placebo effect size. Of course, for an expensive drug, every patient will wish the drug to be effective, will be convinced that it's effective, and therefore leading to a high placebo effect. The studies are unblinded. There are no historical controls to compare the rate of progression in people who are treated to patients who have been included in the past. There are no quantitative data, for example, respiratory effects. These are so important in this disease, but we have never seen the effect on breathing parameters. So Also, these studies that were reported always have small numbers that are heterogeneous in design, follow-up duration, etc. And the endpoints, in some of them at least, are defined post hoc. And we don't know what defines failure. So does a patient who remains, despite being treated, at the same disability level for a couple of years, is it a failure of the drug? Or is it, or do we say that it's good that the patient is stable because without the drug he could have been getting worse? So the results show us that the effect size, whatever it is small. There are poor data on ambulation, for example, on needing a wheelchair, where we have no good data on upper limb involvement, particularly for everyday purposes, and as well as on quality of life, which is so important. So also, I think I want to stress that these retrospective studies do not provide data on NNT. NNT, as you know, is a number needed to treat. So how many patients who have gotten Hoffman disease need to be treated by this drug in order to prevent one of them for needing a wheelchair? This is an important question that we should ask. We don't have the data. And also the dollar issue. So what is the cost-benefit ratio? And we know that these drugs are extremely important. And what is the cost-benefit ratio? What cost-benefit ratio do we agree? And I mentioned already the safety issue for Nucinosan. There is, for example, the need for LP, not trivial in patients with kyphoscoliosis, who may need an anesthetist and imaging to do the study. There are several reports about side effects, including infection, meningoencephalitis or meningitis, bacterial encephalitis, and of course, hypotension, intracranial hypotension. Now, I want you to pay attention to the role of the regularity authorities, because they had very lightly approved these drugs for adults based on data about infants, or for combined groups of infants with adults. They should have required controlled prospective double-blind studies to be done later on, based on strict diagnostic inclusion criteria and needing criteria for stopping medication. So what is the best use of the money? If you go to this patient who is still ambulatory and tell this patient, look, there is a new magic drug that could prevent you from getting worse. Of course, it will not stop the disease completely. The disease may still progress. We don't know how much, or may not. And you may remain in the same situation as you are now. In fact, as you know, our patients are very aware that they could have stayed on the same level for another 3 or 4 years without requiring a wheelchair. And now you tell them, okay, we are going to give you this treatment, which costs a lot, $500,000 for the next 4 or 5 years. Do you want to take this drug with all the combining complications that would occur? We can give you, let's say an exercise. We can give you $500,000, which you can use either to buy this drug or to use it for other purposes, to improve your home, to get a better drug, to get more physical therapy, whatever, to wait for the new drug that may come within the next 4 or 5 years. What would you like? And I'm sure that many of them would say, let's get the money and we'll wait for the better drug to come. So I think that this is something that the authorities should have taken into account. I do not suggest that we do this exercise with patients, but it should have been done by the authorities. And therefore, I think that drugs should not be approved based on small retrospective, open-label, uncontrolled studies. There is no way that these drugs or any drug of the same sort would have been approved for adult based on the SMA data that we have now. No way. It's just by including them together with infants that they have been allowed. And we spent a lot of money on it, which could have been used for other factors. For individual patients, if a patient would come to me and ask for my advice, I would think twice before approving the drug. I would think about his age, how long he has been stable on this level of severity that he is, how severe the disease is, and so on. So the new treatments for spinal muscular atrophy, which are so successful in the young, are they also indicated for adults with SMA? I am not convinced, and definitely not always. And I hope that you'll agree with me, and in the voting which comes next, you will vote for not always. And with this, I will end, but not before telling you, reminding you that our next CONI meeting will take place in Dubrovnik next year, exactly or almost on the same date. And you're all welcome to join us, being able to shake hands, to hug each other, maybe even to kiss each other. Will be a pleasure to be there. And thank you very much for your attention.
Well, thank you so much. It was wonderful. And I think we all agree that next year, all our meetings would be fantastic to be back in person, and I'm pretty sure that's going to happen. So, great discussion, a bit of controversy, and I think we should sort of get into it. You want to respond back, Suzanne, about
Sure.
any of the...
So, thank you very much. Thank you very much for this great presentation, and of course for picking up the most important points and criticisms to address in this issue. And of course, I agree that the gold standard for the approval of a new treatment is a placebo-controlled, randomized controlled trial. And I'm the first one to agree with you that this has not been properly done in SMA. But the sort of Pandora is out of the box, and I think we cannot go back and not offer it to patients. And I do think that, yes, natural history shows a progressive decline of function also in adult SMA patients, and that improvements are possible. And at least in the trial that I showed, there were no pre-selection of patients, but all patients treated in our centers are enrolled into the Smart Care Register and into the MNDnet, so there is no pre-selection. And I think that the study does quite impressively show that it is possible to improve. And I also agree from my own observation and from the data that this is most probable in patients who are still quite well preserved regarding their motor function. But that, on the other hand, stabilization is an important goal. And even for a person completely wheelchair bound and only able to move 2 fingers to control the joystick or to control a cell phone, for this person, it makes a huge difference to maintain this function for a longer time. And most of our patients, they are still very active. They work, they are studying, they are living on their own, of course, with assistance. But I think for these patients, it does make a difference to maintain whatever is there. And that's already an important treatment goal. And of course, I agree that we're not there yet regarding the best markers for adult patients. And that's a major drawback from the clinical trials, that they use outcome measures that have been adapted to childhood SMA, but not properly fit adult patients. And of course, as I mentioned, other markers, other assessments, also addressing quality of life, addressing treatment satisfaction, addressing fatigue, or other factors might be more reliable to understand the working of this drug on the long term. And I also agree that it would be great to have parameters telling us when to stop it. So I totally agree that there are patients in whom it might be meaningful to stop the treatment after a period of time, and that we're not there yet, that we might need criteria also to, as in the example of secondary progressive multiple sclerosis, to stop the treatment. patients at some time point, and that we need to find that out in the next years, and that this should be a line of research that must be pursued.
That's great. Thank you. Dr. Korsen, any back comments? I'll add a few, but I'll wait.
Well, thank you very much. I hope you hear me because there was background noise just now. Jeff, maybe you can turn off your mic. Maybe it's coming from you. Anyway, thank you very much. I think point is well taken, Susan, and thank you very much for it. And I think that we agree. I think you agree with me, I hope, that not every adult patient with diagnosis of SMA should be treated. I wonder whether you treat every one of them, even if there are like some patients in the study that you showed, I think were over 50 years old at onset, and maybe the deterioration rate there was very, very low, very slow. Maybe they should not be given. So I think that every individual cases should be judged on their own. And I don't think, I mean, this is a costly drug. And even if under the circumstances in Germany or in Israel or in many other countries, the patient does not have to pay, somebody does pay for it. It's an expensive drug. And so this is, I think, an important issue. Now, I think that you said that your experience is good, that patients still maybe have deteriorated, but very slowly. I wonder, but you didn't give a number. How many patients were stabilized? How many patients deteriorate? By how much they have deteriorated over a year or so? And again, I mentioned before the placebo effect. What you saw included not only the drug effect, but also a placebo effect. And since you don't have placebo control, you don't know what is the actual effect of the drug. So I think that this is an important issue. We need the data. We don't have the data. I agree that with the data that we have, the information that we have, many patients should be treated. But the question that we have to vote on is whether you always have to treat patients, because you said yes, and I said not always. And I hope that many of the audience will agree that not always is a better choice. And another point is that you say that you don't have selection bias, but there must be selection bias. Not all patients in Germany come to your center. There are many who do not, and there is therefore some sort of a bias that will bring them there or not. We don't have enough follow-up, as you agree. All the follow-ups, all the studies had very short follow-up. We don't know what happens in the long run. We don't know whether we need to administer a booster. In the infant studies, you know, it varies depending on which agent you are using. How often is it needed? Is it needed at all? Or it's the same thing now with the COVID-19, that we're asking ourselves, do we need a booster or not? And I think that, and the question is, of course, different for each disease, but it's a real issue, and we don't need to waste the money. $500,000 maybe in each of injection coming every 3 or 4 years. So it's not a minor issue, and we should not say we have a drug, it is possibly or probably effective, let's give it to everybody. I say no, don't give it to everybody automatically. Think individual. We are now in the era of personalized medicine, and personalized medicine includes also taking into consideration this. And again, I brought the example of a person who is mildly disabled, maybe stage 3, and they have been, you know, getting worse, but rather slowly. They're still ambulant, they're still independent. And now you offer them, in theory, of course, I don't mean this is a practical issue, $500,000 that they can use for whatever they want. If they want to buy the drug, they will get the drug. If they don't want it, they can use it for other medical purposes for their own. I think a substantial number may have said, I'm doing fine. I'm not going to spend the money on the drug right now, maybe in the future, but for now I will use it to improve my terms of living, my conditions of living. So again, I think it's up to the patient. And you should not say, okay, you've got SMA, here's a drug, go and get it, and that's it, and come back for follow-up next year. No, I think this is a more serious issue that you should really take into account. Personalized medicine means that you have to discuss also the economic part of it when you decide, or when you let the patient decide together with you about whether they should get a treatment or not.
Suzanne, before you answer, I'm going to add a few things because each of you have said something. So I think all would agree that more is better. This is challenging to get long in compared to infant.
Can you speak up, please?
Type 1 SMA. Sorry, I thought you could hear me. So I think we would all agree that more is always valuable in any clinical endeavor. It's probably a much more challenging problem across the world to get detailed long data. This is not rapidly progressive like ALS or infantile SMA. But one thing I think you miss in your agreement against is the fact that as patients progress, this is irreversible. When they lose those motor neurons, because that's what's happening, they're gone for good. There is no drug that's going to bring that back. So the sooner you use that drug, the sooner you protect against the future loss of motor neurons. Now, you're right, it might be mild, but at some point it won't be. And the earlier you prevent loss of motor neurons, so this is purely based on the science, that's critical. And these interventions have that ability to prevent that future loss. Whether or not there's a biomarker to tell you how quickly, the way you heard about in ALS, whether neurofilament will truly tell you the progression, could be useful in making those decisions. And I don't know, Suzanne, if you're actually using that, or your community's using that. But I'll underscore, this is irreversible. You're cutting off a finger at a time, and no drug's going to bring that back. And therefore, the earliest use of a drug like this prevents the future loss of motor neurons.
Yeah, thank you for that comment. That's an important thing. And again, every loss is crucial for the patient. Losing the ability to climb a stair is crucial, but also losing the ability to move the last remaining finger that still has some way of moving is crucial. And so I mean the initial question was yes or no, and I always go for yes. And of course, the not always is mostly true because the world is never black and white. So, and of course we not all patients wish the treatment. We have patients who decide against, and of course we do not go around and force patients or impose a treatment to patients. But yes, I still think it should be offered, at least for a period of time, before we may decide. In several cases, it doesn't make sense. Patients keep deteriorating, and patients do not benefit. So there might be patients where we need to stop. But at the moment, yes, I still think it should be offered to every patient, if they are aware of the risks, of course, of the safety issues, and then if they decide to choose it, but the choice should be offered.
Any additional comments by either of you? I mean, there's no question pricing, and this of course varies from, this is a worldwide meeting, varies from country to country, and pricing can be a dramatic and an annoying thing. There's no way to, now I'll bring my own bias. It's ridiculous pricing. There's no way. The drug itself doesn't cost that much. And when these drugs first came out, and companies will always argue, well, we have to recoup cost of the trials. Yeah, these were tiny trials compared to standard drug trials. So I to this day, I still, I'm leaving out expletives, not happy with the costs that they charge for this kind of drug. But it's remarkable science, and you're essentially preventing the progression. I can't underscore how important that is. Amos, earlier you mentioned the point of in an earlier segment of these discussions about curative therapies. Curative therapies don't exist for degenerative diseases. We can't bring back neurons that die. We're not salamanders that can regrow limbs, and so everything about what we're doing is about possible prevention or powerful drugs that prevent progression. Clearly, this therapy in children does that. And if by the time an adult comes around and they've lost, I'll make up a number, 80% of the motor neurons, and now they're slowly picking off the remaining few, I'm repeating myself here, that's important because I know to an ALS patient, merely holding on to the ability to hold on to a spoon for a longer period of time is really valuable. And I think Suzanne mentioned that. Sorry, I'm coming down on you. I know people might agree with you about the costs and choices, but from a patient standpoint, these are important and valuable therapies.
So you cannot compare this to ALS. ALS is lethal within a year. Here, patients will live forever with SMA. They will not die from SMA. So it's not a correct comparison. Now, of course, every neuron that is lost is a failure, irreversible one. Question is how much, firstly, how much do you pay? Are you going to pay for saving one motor neuron? $1, $10, $50? What happens if next year another drug will come up for SMA, which will cost $1 million, not $500,000, but $1 million, which will be more effective in some studies than the present ones. So will you tell the patients to continue on the previous drug and add on top of it this new drug, which is a different mechanism of action because it may be supplemental, and then you triple the expense, or what will you do? And I hope you all agree. Jeff, I think that had you been in the advisory board, the FDA advisory board, on these drugs, and the discussion would have been separated for infants and for adults. Do you think that the adult data would have been sufficient to convince you to approve the drug? I'm sure not. No double-blind, small numbers of studies, small number of individuals in each one. The studies were done on the different measures and different protocols. So there is no way that this drug would have been approved. So just the fact that it has been approved by some sort of a gimmick that the drug industry did by combining the infants and the adults is a problem that the FDA and the EMEA should have dealt with, and I think they didn't deal with it properly. They should have encouraged the industry to do proper studies and to show us what is the real benefit, and then to say for the authorities whether the drug should be approved, that's one, and whether the government should pay for this. So in Germany and in Israel, not every drug that is put on that is proven to be effective will be reimbursed. The government decides that there is a cap. So it decides that, so if they decide that SMA for adults should be included, then this means that some drugs for cancer patients, for example, would not be included. So I think that there is a choice that this is not for us as clinicians to do, but this is a decision that should have been made. I think the wrong decision has been made to approve it based on infant and the small children data. The disease in adult is a different type of disease, although it may be due to a similar genetic mechanism, and therefore it was wrong to prove it from the beginning. And for us, we should think individually, personalized medicine. I don't say that the drug should never be used, of course. Given what we do, we should give patients the opportunity to benefit from the drug, but not necessarily everybody.
Any other comments? I think you make valid points, certainly about, there's no question, I think all of us as academic neurologists see data as the most important. We can't change history. The FDA did what it did. Patients know they have access to a drug, and I don't, to be clear, I personally don't see adult SMA patients. I would disagree with you that ALS is not a year in progression. ALS is extremely valuable. And a patient that has a 20-year course, which I see plenty of, a 10-year course, a 1-year course, and a 5-year course, they're all coming to us as clinicians and healthcare providers as help me with my disease. I'm progressing. And we have an obligation there. And the first obligation is to do no harm. As long as this drug is safe, I think we've done no harm. Harm might be considered cost. We all live in different parts of the world. This is not as much on our table here in the US as it is for other countries. And I'm not going to speak for other countries. But then it comes down to, and I'm now again repeating myself, are there different classes of patients? So in a sense, I agree with you. Not everyone should get it. But the real question is, how do you determine that? Who should get it and who should not get it? And I would take money out of that equation. It's more about clinical. And just because someone's relatively slowly progressing does not eliminate them from the need for a drug that prevents this. And I'm not going to tell you I know that answer. Suzanne, of all of us, works mostly with these patients and will have a better sense of who, in her honest view, would benefit less from it than someone else. And I don't have that answer. And I'm sure there are really slowly progressive patients. There is variability, no doubt. And having those tools to understand that variability, this is what some of this conversation today has been about. Having tools to sort of parse out patients is important. But the fact is, we're in an era, you call this personalized. I would argue this is all personalized. We have a gene therapy for a known gene defect, and these patients carry it. Whether there's variations on the theme becomes then the physician-patient discussion. Suzanne, any last words?
Anyway, no, I mean, I agree. I mean, I think it should be offered to all patients, but maybe not all patients should be treated for years with it. And maybe we should really work on developing criteria on whether it can be meaningful also to terminate the treatment after a certain time. And there is a lot of research to be done regarding outcome measures and biomarkers. And this is just the tip of the iceberg that we've seen so far.
Well, that's great. It's been a great discussion, and I think we're ready to start voting for those who've been listening in on this. Please go ahead and vote. They'll set the voting system up. I don't know how they do that, but I'm sure they do.
I'm glad now.
But not wiser.
All right. So thank you for listening in. And we started a very heavy yes, and by a great presentation by both Suzanne and Amos. And he convinced a number of you to sort of become 50-50. A little more no than yes. So different opinions, different parts of the world have different opinions. And just to let you know, I vote yes. So I'll add, and I didn't vote on this, so I'll mark it at almost a 50-50. But thank you. Thank all of you for participating in the last few hours in this discussion of various elements of motor neuron disease. And look forward to the rest of the presentations at the meeting. Thanks again for all of you to attend.